Myasthenia gravis. Myasthenia gravis is a chronic autoimmune disorder affecting the neuromuscular transmission of impulses in the voluntary muscles of the body. It is due to an antibody mediated attack against acetylcholine receptors at the neuromuscular junction. Cardinal features are muscle weakness and fatigue. Pathophysiology and etiology. Depletion of acetylcholine receptors at neuromuscular junctions brought about an autoimmune attack. The origin of this autoimmune response is unknown. The reduced number of acetylcholine receptors results in diminished amplitude of end plate potentials. Failed transmission of nerve impulses to skeletal muscles at the myoneuronal junction results in decreased muscle power, clinically manifested as extreme fatigue and weakness. About 80% to 90% of patients with myasthenia gravis have serum antibodies to acetylcholine. Thyroid gland abnormalities are present in 80% of patients. An acute myasthenia crisis may result from natural deterioration, emotional upset, upper respiratory infection, surgery, trauma, or adenocorticotrophic hormone therapy. Cholinergic crisis can result from over-medication with anticholinergic drugs, which release too much acetylcholine at the neuromuscular junction. Brittle crisis occurs when the receptors at the neuromuscular junction become insensitive to anticholinesterase medication. Women are 3 times more susceptible to developing myasthenia gravis. Clinical manifestations: extreme muscular weakness and easy fatigability, visual disturbances, diplopia and ptosis from ocular weakness, mask-like facial expression from involvement of facial muscles, dysarthria and dysphagia from weakness of laryngeal and pharyngeal muscles. Impending crises are sudden respiratory distress, signs of dysphagia, dysarthria, ptosis and diplopia, tachycardia, anxiety, rapidly increasing weakness of extremities and trunk. Diagnostic evaluation: serum test for acetylcholine receptor antibodies positive in up to 90% of patients. Second one, endrophonium tensilon test. IV injection relieves symptoms temporarily. After injection, a marked but temporary improvement in muscle strength suggests myasthenia gravis. Also differentiates myasthenia crisis from cholinergic crisis. Edrophonium. Edrophonium. Edrophonium tensilon. Third one, electrophysiologic testing. Electromyogram EMG reveals decremental response to repetitive nerve stimulation. Fourth one, CT scan to assess enlargement of thymus gland. Management. Nursing diagnosis assessment: assess cranial nerve function, motor fatigability with repetitive activity and speech. Observe eye muscles often affected for ptosis, ocular palsy, diplopia. Assess respiratory status, breathlessness, respiratory weakness, tidal volume and vital capacity measurements. Management: with treatment, most patients can lead fairly normal lives. Anticholinesterase drugs such as neostigmine and pyridoxstigmine to enhance neuromuscular transmission. Immunosuppressive drugs such as prednisone and azathioprine. When weakness is not adequately controlled by anticholinergic medication, immunosuppressant treatment is often permanent. Plasmapheresis removes antibodies from the blood and it is used for patients in myasthenia crisis or for short-term treatment of patients undergoing thymectomy. Thymectomy for those people with tumor or hyperplasia of the thymus gland. Interventions for crisis: first one, immediate hospitalization. Second, edrophonium to differentiate crisis and treat myasthenia crisis. Temporarily worsens cholinergic crisis. Unpredictable results with brittle crisis. Third one, aggressive respiratory support, tracheostomy, ventilator, vigorous suctioning. Fourth one, plasmapheresis. Fifth one, neostigmin, prostigmin IV for myasthenia crisis. Sixth one, discontinue anticholinergic medications until respiratory function improves. Give atropine to reduce excessive secretions for cholinergic crisis. Complications, aspiration, complications of decreased physical mobility. Third one, respiratory failure. Nursing interventions include minimizing fatigue, preventing aspiration, maintaining social interactions, community and home care consideration. Patient education and health maintenance also needed. Instruct the patient and family regarding the symptoms of the crisis. Review the peak times of medications. How to schedule activity for best results. And stress the importance of scheduled rest periods before fatigue develops. Encourage patient to wear medical alert bracelet always. Avoid exposure to colds and other infections. Advise patient to avoid alcohol and tonic water. Thank you.